Yes, Dr. Ankita, we are right here. So let me just inform you that we have about 652 registrations today. So
That's
because I have just started Make It Live, so I think slowly people will join us. So we have 2 minutes,
right.
so we can just wait for our attendees to join us.
Right, sir.
Yeah. How's Mumbai treating you now?
Uh, a lot of people have started working, but I don't find it still safe. It's very risky right now. I've like started emergencies, but I think it's better to wait it out this month and
Yeah.
maybe sometime next. Yeah, next month will be a lot more better.
Yeah.
Yeah.
So, okay, Dr. Ankita, I think we will start now.
Yes, sir.
So, let me formally welcome you first. And
Yeah.
very good evening, Dr. Ankita.
Good
I'm
evening, sir.
happy to see you on this South Asian Association of Pediatric Dentistry platform. And
Thank you,
it's
sir.
a very, very new topic. And I extend very, very good evening to all my friends who always come here. And today I can see a few of the faces, new faces. So definitely I'm going to connect with all of them during the webinar because once you will be presenting, I will be uh, talking to all people through the chat box.
Right. Thank you.
So first of all, before I request you to present your webinar, let me formally introduce you to our attendees. And in the question and answer section round, I will be introducing all attendees to you also, right? Because you may not be aware of all the names, but definitely I will introduce all of them to you.
Sure, sir.
So today, I'm very happy that we have a very one of the most beautiful pediatric dentists, I must say, in India, maybe abroad also. That is none other than Dr. Ankita Shah.
Thank you, sir.
Dr. Ankita has done post-graduation in pediatric and preventive dentistry from YMT Dental College in 2013, and this school is in Mumbai. She is director and founder of Dentition. This is a pediatric dental clinic as well as a breathe sleep center. And she has done fellowship in myofunctional science, especially in orthodontics, from Barcelona in 2017. She is certified by Myofunctional Orthodontics, which is presented by Myofunctional Research Corporation, MRC, and Australia. She is certified by Gold Learning Tongue Tie Symposium. She is also certified by Global Laser Oral Tie. She is the first and only Indian ambassador of the Breathe Institute, Los Angeles, United States of America. She is nominated for Specialist Dentist of the Year 2019 at Femdent Excellence in Dentistry Awards. So here I present all of you, Dr. Ankita Shah.
Thank you.
Yeah, Ankita, please start your presentation and heartiest welcome on behalf of entire South Asian Association of Pediatrics.
Thank you so much, sir, for your kind words. I'm going to keep this webinar very interactive, and I want you all to start posting your questions whenever you all feel comfortable. We'll attend to all your questions, and I'm going to be starting to share my screen now. Yes.
Yes, it's fine. It's visible. You can just hide the screen sharing button so that full screen is visible. And Ankita, I will be with you throughout your journey of webinar, but my microphone and webcam will be off.
Perfect.
Whenever you will need me, I will switch in immediately.
Perfect, sir.
Wish you all the best.
Thank you. So very good evening to everyone, and I'm extremely excited to be introducing you all to Sleep in Pediatrics. It's my passion to make these kids breathe and sleep better and live healthier and happier lives. So here's a little about me. Sir's given an enough introduction, but I'd like to highlight you through a little bit of my journey, how I came across sleep and breathing. I'm the director and founder of Dentition, and as you all know, that I'm also a pediatric and preventive dentist, but I'm an airway-focused pediatric and preventive dentist. When I first learned that, there was some soft tissue malocclusions and muscle dysfunctions which were causing jaw malformations and there were crooked teeth, I was a little surprised to hear that. So I went on my journey to learn, unlearn, relearn, and I realized that it is not just this. There's a lot behind this, and we are not seeing the real picture over there. And when I learned more and more, I realized that it's sleeping, breathing, jaw growth, these all are interrelated. And that's when I started a multidisciplinary approach towards sleep and breathing disorders. And we're going to understand this complete role through this presentation today. So here's a little about my practice. Now, sleep and breathing generally has multiple causes. So I always recommend that you should view the causes from different viewpoints, experience, and expertise. It also has a very multidisciplinary approach. To get the successful treatment, it is best to approach sleep and breathing from many angles. So I always say that there are different perspectives to this common problem. Try and view it from every angle. If you want to achieve success for these cases, it's best to keep a very open vision. Now, what is oral and facial development? Is it genetics or environmental? Sir, can we have the poll going in here?
Sure. Okay, here it is. So, because the results are more toward genetics, but it is shifting. But yes, certainly more toward genetics. It started with 100%, but now roughly it is coming 63, 64, then 69, and then it's changing because I think people are polling.
Yeah.
So, but yes, it is more of genetics.
Okay.
So it is 60 and maybe a 40. That's what.
Okay.
Yeah.
So I'm going to start the screen share again. And here we are. So let me break a little bubble here. And genetics is just the gun, or it's loading the gun. But environment is something that's pulling the trigger. And you won't believe, we all have heard this since many years. We all have studied this Melvin Moss theory, the functional matrix theory. What did this theory tell us? We've completely ignored the epigenetic factors. They clearly stated there that there are no genes for bone growth. And his hypothesis was that the whole bone growth or the blueprint of this bone growth is dependent on functional matrices. And these functional matrices compose of our muscles, tongue, cheeks, lips, nerves, blood vessels, connective tissue, fascia, tonsils, adenoids, airway, etc. And any kind of stimulation to these functional matrices is going to cause a stimulation of growth in these bones. Not only this, but even Graeber implicated that the muscles are going to play a very important role in the development of poor orofacial growth and malocclusion. What is literature showing us over here? What is the soft tissue dysfunction? It's nothing but a mild alteration of your muscular activity. And what Dr. Ramirez is stating over here is that we as dentists need to know what is soft tissue dysfunction, and is this soft tissue dysfunction causing a malocclusion. We should have the ability to recognize this. Not only this, but he's also stating that whenever we devise a treatment plan, we must keep into account the soft tissue dysfunction. We must see whether we are achieving an equilibrium balance between the tongue and the cheeks and the mucosa, or the lips, and around at the same time aligning the teeth also. So what's the best choice of appliances here? Like the best choice would be functional orthopedic appliances, which is even relieving the muscle pressures, correcting the muscle dysfunction. It is also going to correct our malocclusions, and we'll have more stable and better results here. So what is these orofacial myofunctional disorders, Now, whatever soft tissue dysfunctions that we spoke of is going to be visible in the form of orofacial myofunctional disorders to us. So what are these disorders? What are we going to see? We're going to see atypical chewing or swallowing. We are going to see some malocclusions. We are going to see some kind of mouth breathing, speech problems, non-nutritive sucking, thumb sucking, posture, like a forward neck posture, clenching, TMJ disorders, and sleep disorders. Now, through our evolutionary process, let's see what these previous generations had. They have, look at that forward growing jaw. Even here, the Neanderthals also had a forward growing jaw, but they had nice wide jaws also. But in our current time, or the present humans have a recessed maxilla here. They have a downward and backward growing jaw. They also have a narrow jaw. So what is all this doing? Narrowing the nasal cavity, narrowing the airway right behind the jaws. And this is all causing a lot of more problems to the airway and nasal breathing. And what research is telling us that this resorption of the maxilla starts right from the age of 5 years. Now, when we look at hunters and gatherers, and when we look at modern industrial man like us, why are we facing so much of crooked teeth, and why do we have impacted third molars? It's not because the teeth are becoming bigger. It's because our arch lengths or our jaws are going smaller. And why is this happening? Look at the change in the size of the muscles of mastication. That has changed. The arch length has changed. We are having a backward growth of the skulls. So what is changing in today's time that even like our skulls are not growing in the alignment of what the hunters and gatherers had? So there is soft and mash diet. Now, because of the soft and mash diet, we are not utilizing the muscles of mastication enough. There is a change in farming methods. Now, this change in farming methods, the fertilizers are affecting the gut immunity, and it's also causing a lot of systemic inflammation. There is an increased bottle feeding and pacifier use. Now, this increased bottle feeding and pacifier use is going to deepen your palate. It's going to cause a lot of malocclusions as well. Increased screen time. This is one of the most surprising factors, but that is causing habitual mouth breathing, because kids generally sit in front of, those iPads and TV like this. And they're going to start habitual mouth breathing there. Mouth breathing per se has multiple reasons. Oral restrictions, skeletal and soft tissue dysfunctions, which we will discuss in our further slides. Before I proceed ahead, I want you to first understand what is pediatric sleep disordered breathing. And the purpose of showing you this is it's a spectrum. It's not one thing. It's a spectrum of things which are happening over here. It could be mouth breathing or noisy breathing. It could be upper airway resistance syndrome, or it could be obstructive sleep apnea. So mouth breathing and noisy breathing is one of the first signs that there is something wrong. This child may present to you with a dry mouth. There may be frequent cavities, poor oral health. These kids are often associated with habitual mouth breathing also. This child may be falling sick quite often. There'll be frequent colds and cough, tonsils, adenoids, allergies. There may be a lip tie, tongue tie. There may also be an unresolved orofacial growth or a poor orofacial development. Now, when it is UARS, basically you are not having a complete loss of oxygen. But what is happening here is you're going to get a lot of arousals because you're going to struggle to breathe right. Okay, when you're struggling to breathe right, you're going to have frequent arousals, and that will lead to a disturbed sleep. Whenever there's a disturbed sleep, the child is going to seem very hyperactive. They may have attention issues. So these children mostly represent as ADHD in a couple of cases. The tonsils may be largish, but not so big. There may be a high arched palate. There will be soft tissue dysfunction as well. Now, when it comes to obstructive sleep apnea, when they are losing oxygen every few hours, that's when the medical stream professionals start treating it. And that's the time when you will see the child suffering from nightmares, bedwetting, anxiety and behavior issues, poor school performance, stunted growth, very big tonsils, poor maxillofacial growth, restricted arches, even restricted frenulum. So what I'm saying here is that why can't we treat them early at mouth breathing? Why do we really want the child to suffer through this whole thing and reach at a stage of sleep apnea? We as a pediatric dentist, we play a very important role over here by identifying these kids early on. And I want to stress on this very important factor here. Remember that this is a spectrum and a syndrome. So you're not going to see 1, 2, 3, every point of everything in that child. But you need to look at that overall picture and then make your diagnosis of pediatric sleep disordered breathing. Now, this slide has been adapted from Dr. Suruj Zagi. He's a world-renowned ENT and who's also mentored me. Now, what he says that mouth breathing eventually progresses to noisy breathing. Noisy breathing progresses to snoring, and that progresses to obstructive sleep apnea. But he also makes a very important statement here that not all mouth breathing gets converted to obstructive sleep apnea. But obstructive sleep apnea always starts with snoring, and that always starts with noisy breathing, and that always starts with mouth breathing. So we have to start early, give therapeutic interventions at mouth breathing in order to reach that stage of obstructive sleep apnea. What is research telling us about the prevalence of obstructive sleep apnea? Or it's just 1 to 2%, but we often see snoring, UARS, and habitual mouth breathing more in children. So these are the stages where there is no oxygen loss or you're not losing breath, but there are n number of researchers telling you that even mouth breathing, noisy breathing, snoring, UARS is causing the same consequences as what we are seeing for obstructive sleep apnea. So it's very important that we start early through the childhood. Now, what are the causes of sleep disordered breathing? Tonsils and adenoids. We've commonly just heard that tonsils and adenoids cause sleep, but it's just the tip of the iceberg. There's something really deep inside that is causing the fire. The various risk factors could be turbinates, adenoids, septum defects, tonsils, high arched palates. Now, high arched palates cause a reduced nasal space. I want you to imagine over here, if that's your palate and that's your nose here, if the palate is going deeper, what's going to happen? We're going to have a reduced nasal space over here. Mouth breathing, which is going to change the position of the jaws as well. It's going to affect your orofacial growth, retruded jaws, forward neck postures, tongue posture, tongue position. But what was more important to be known for pediatric OSA is that it was seen more often because of a poor orofacial growth. And this was observed by Dr. Guilleminault. So here we as pediatric dentists play a very important role. What are the potential consequences of untreated pediatric sleep disordered breathing? What can happen if we just let this go? So these kids may have moody behaviors. They may be exhibiting bullying behaviors. They may be inattentive. Attention concentration is affected. There will be a poor academic performance. These kids may also experience some form of bedwetting. Now, when we move from deep sleep to light sleep, a fight and flight response is activated. That's a sympathetic drive is activated, and this causes bedwetting. Even growth hormones are released in your deep sleep, and not producing enough growth hormone can result in slow or delayed growth and development. Even hormones related to satiety and obesity are released in deep sleep. So children tend to feel more hungry and they are going to have childhood obesity. these kids also are at a high risk for cardiovascular disorders like high blood pressures, diabetes, and more other problems during their adult life. So what's so much in this shape? What's really happening here? So any form of malocclusion is going to cause an airway narrowness that is resulting in also some eating issues, speech issues. It's going to affect your aesthetics also. But when there is an airway issue, you're going to face that spectrum of the sleep disordered breathing. The minute you're going to face that, there will be hyperactivity, ADHD kind of symptoms. There will be a general growth which will be decreased, and also the orofacial growth which will be affected. Frequent tonsils and adenoids, allergies, and clenching of teeth. Now, in the struggle to breathe, you're going to get your jaw forward. And in this unstable position and with the sympathetic drive being active, you're going to start clenching your teeth. Now, when there is obviously a poor orofacial growth or a soft tissue dysfunction, you're again resulting in malocclusion. So what happened here? Malocclusion, it started with that, ended with that, and in fact, it's worsening the symptoms over here. So it's going to be a vicious cycle if we don't correct the malocclusion. Now, this is a very interesting study by Dr. Gimino, where they actually studied certain monkeys and they induced nasal resistance in them. They went through a lot of orthodontic literature also. And they also studied a few children who were suffering from OSA, and they treated them with tonsils and adenoids. But yet they saw that there was a recurrence of pediatric sleep or obstructive sleep apnea. And what they found was there was a very strong association between normal orofacial muscle tone and the orofacial growth with pediatric SDB. So here, again, we as pediatric dentists are going to play such an important role here. What is more research telling us? We all have heard of adenoid facies since 1980s, 1868, and all through our pediatric curriculum also we've heard about it. And these adenoid facies are changing the orofacial growth. This orofacial growth change is going to cause mouth breathing, which is going to lead us to more spectrum of SDB. This mouth breathing is also going to affect the orofacial muscle tone, which will further worsen the malocclusions. So it's very important for our children to understand how to use these muscles correctly in order to have the right facial growth. There were also studies where they studied that these muscles of the tongue, face, cheek, lips had an abnormal muscle tone when they were induced with nasal resistance or mouth breathing. So what they concluded in this research was that mouth breathing is an important marker that there will be a poor orofacial muscle tone. They also found that whenever there was mouth breathing, there should be some form of obstruction. It could be any obstruction in the nasal or pharyngeal airway. There should also be some developmental interplay. There should be some abnormality present over there, between the muscle tone, between the breathing route, or between the structural growth of your upper airway. So what I'm saying here is that all these physiologic functions of suction, mastication, swallowing, nasal breathing, these play a very important role right from infancy to stimulate the growth of the oral, of the face and the jaws. Remember the Melvin-Morse theory, the functional matrix hypothesis? This is the functions that is going to affect your growth. This is another very interesting research where they found that the lengths of the maxilla and mandible, forward facial growth, a longer anterior face, and even like a retruded mandible, a posterior airway space which is small, or even an inferiorly positioned hyoid bone, these all prove to be high risk factors for OSA. This was one of the most recent researches where they found that the prevalence was almost 33.3%. And they also found a very strong correlation with overjet, They also found that correlation with posterior cos bites and also with an anterior open bite. Now tell me, how often do we see these malocclusions in our practices? Almost like 1 in 5. How many times have we ever went and screened SDB when we see these malocclusions? None of us did that before, right? So it is time for us to understand that whenever we see malocclusions of orofacial growth, see a muscle dysfunction, it's time to start evaluating the SDB of that child also. Now, this is another very interesting research where I'd like to tell you that if there is a class 1, a class 2, or a class 3 malocclusion, your jaw is going to be forward, backward. And imagine the pharyngeal space right behind those jaws. It is going to be altered, right? So what I'm trying to say is that why can't we consider the entire somatognathic system as one unit where one part is influencing the other part rather than considering them as individual factors? And this study also found that, the whole growth pattern is being changed by the respiratory function. When you're mouth breathing, it's causing the lowering of your mandible. It's causing the lowering of your tongue. It's causing an extended neck posture. So this is a very interesting book, Jaws, by Dr. Sandra Kahn. And she's an orthodontist herself. And what she said that when it came to her children, she didn't want to do traditional orthodontics because that was narrowing the airways. So she wanted to look at airway orthodontics and forward odontics where the jaws were growing forward. She also gives a good highlight on what has changed in these generations that we are not having the right facial growth. And this picture has been adapted from this book where we can see the profile of a mouth breather. We're going to see a completely downward and backward growth pattern. We're seeing a recessed maxilla. We are seeing deep sunken eyes. We're going to cause the narrowing of the airway right behind over here. Forward neck postures. So can you imagine, have you seen these long facies more common now than what we have seen before? So Dr. Maria has given these really nice guidelines for recognition of mouth breathing, where we can look at the visual assessment. We can look at some questions to assess it. And she also gives out some breathing tests. Now, these breathing tests are something that we've commonly learned through our literature and even through our post-graduation, where we look at the fogging of the mirror. We place little water in the mouth and ask them to hold it. Or you can even use a micropore tape and check if the child can breathe or no. Now, when I'm saying these breathing tests, we cannot recognize that the child is a mouth breather from these tests. But what we can recognize here is that is the mouth breathing because of a habit or is it because of an obstruction? And she also mentions over here that you should take at least a minimum of 2 breathing tests to come to a diagnosis. And once you come to a diagnosis, that's only when you will be able to come to a treatment plan. So what I'm saying here is that in normal individuals, almost 60% of your orofacial growth is completed by 6 years and 90% by 11 to 12 years. Whereas the brain development is completed by 90% in the first 5 years of the child's life. So since we all know what is the potential consequences of SDB, do you think it's wise enough to delay treatment for these kids? Is it okay or fair to have them a poor brain development? Is it okay to get them to a stage where we can't change the growth pattern? So all I'm trying to say is that prevention is the key to SDB, and we as pediatric dentists are going to look into this. This is the current gold standard for treatment of pediatric SDB is continuous nasal breathing. Now, what the study found that whenever there was a treatment done with tonsils and adenoids, there was still a complete relapse of a lot of cases in their adolescence. There were full-blown symptoms of obstructive sleep apnea seen when these kids turned into adolescents. Why did that happen? Because nasal breathing was not reinstituted. We just corrected the tonsils and adenoids. We never taught the child to breathe through the nose. So they continued mouth breathing, and we again are in the same space where we are actually worsening the sleep disordered breathing. So what they are saying is the only valid finish line is nasal breathing through the day as well as during sleep. This is a very interesting research, again, where they studied 24 children, and these children were treated with adenoids and tonsils again, and some were treated with orthodontics, keeping that into account. Some didn't require any form of orthodontics. But of these, 11 of them completed the myofunctional treatment, that is the oral myofunctional therapy, and remaining 13 didn't complete it. So the ones who completed it had a complete resolution of their symptoms and also the AHI. But those who didn't complete were unsuccessful and they've had a long relapse. So what this research is saying that orthodontics alone is not going to treat you successfully. A combination of orthodontics and myofunctional therapy is the only successful treatment for pediatric sleep disordered breathing. Every era is bringing a change in all the lines of thought and work. So it's very gratifying for our profession to know that we can now closely work as dentists along with the medical stream and resolve this epidemic of sleep disordered breathing. Even ADA in its policies is mentioning that dentists are the first ones to identify the symptoms, and we can discuss this with the patients. We are the ones who can screen, take history, clinically identify the signs and symptoms, identify the growth and development, identify the risk factors to airway. We are the ones who can even deliver oral appliances. And they also mentioned that we should continually update our knowledge in dental sleep medicine. FDI is also stating the same thing. They are saying that it's very important to understand our role as a dentist and what's our role in this whole multidisciplinary approach. We should be trained to treat SDB patients. So what is oral myofunctional therapy? We've heard this quite often from me, and I'm sure all of you all have heard this very new oral myofunctional therapy coming quite often. So any kind of changes in our oral function is going to influence your facial growth, right? And if we need orthodontics, which is almost, I think, 1 in 3 needs it today, that means there's definitely some problem with your muscle function. Now, as this name suggests, it's oral, that's your mouth, facial, that's your face, and muscles, that's muscles of your mouth and face, require some form of a correction. So this is basically a therapeutic intervention to correct your oral facial muscles so that they can perform the right functions, that is of swallowing, breathing, chewing, etc. And they can also have a normal resting posture. So is this myofunctional therapy and new? So in 1918, Alfred Rogers mentioned that facial exercises were very important for improving the functional activity. And he also stressed that it's very important to look at facial development rather than just mechanical orthodontia. So what he is trying to say over here is that muscle training is very important for correction of mouth breathing. He's also stating that when we as orthodontists are changing the growth or the position of the jaw, maybe forward or backward, the muscles have to be retrained to adapt to this new position. So what Dr. Alfred Rogers did in 1950, he presented to the American Association of Orthodontics in Chicago, and he titled this paper, A Restatement of Myofunctional Concept in Orthodontics. And he stressed that it is not only very beneficial for the orthodontist, but it is extremely important and it has many benefits for a growing child. If it is beneficial for a growing child, what are we doing as pediatric dentists? We are the ones who are going to provide this to the child. So what are the goals of myofunctional therapy? They're pretty simple, like lips together, breathe through the nose, tongue up on the palate. So now we are here at this problem-solving game. What is preventing the child to keep their lips together? What is preventing them from breathing through the nose? What is preventing the child to get the tongue up on the palate? This is how we are going to do our analysis and then come to a conclusion on how to treat this child. The idle tongue position should be right on the roof of the palate. This will keep your airway nice and wide open. But if it is resting low, this back of the tongue is going to narrow your airway. The minute your airway is narrowed, there's going to be resistance to the flow of air. And if there's resistance to the flow of air, it's going to make nasal breathing difficult. So when it is resting on the palate, it has almost 500 grams of force compared to braces, which has 1.3 to 1.7 grams. And it's going to give you a nice wide U-shaped arch. But if it is resting low, it's going to give you a V-shaped arch, crooked teeth, and also a narrow nasal cavity. Remember what I said? Deeper palate, narrow nasal cavity. So is mouth breathing and myofunctional stuff new? Actually, no. It's just the paucity of our present knowledge in the etiology of orthodontics that is compelling us to attach the cause-effect relationship at a different end. But how nice it would be if we can go backward and understand that the old is only the new, and can we understand the cause-effect relationship in a different way? So what I'm trying to say here is that we've heard that there are procline incisors. Now, we've always seen that that happens because of certain habits or mouth breathing. And we assume that these habits and mouth breathing are the primary causative factors. But is it possible that these could also be merely symbiotic related factors? Let me give you an example here. Now, look at this normal swallow. Now, the tongue is resting nicely high up on this palate. Lips are at nice rest position and you're continuing the normal swallow. But when you're thrusting, the tongue is going to come down. It's not resting on the palate. It's going to be pushing between the teeth. And then you're going to thrust and get your swallow completed. Now, in ideal cases or till now, we would always say that the tongue thrust is the primary causative factor for this malocclusion. But can we change our vision a little over here and see that there are tonsils over here in this particular case? But there could be also other reasons which is causing the tongue to remain low. Now, if the tongue is going to be pushed to a low position, that is going to also cause a tongue thrust swallow, right? So the primary causative factor could be the tonsils, whereas the tongue thrust swallow could be a mere symbiotic factor. Let me give you another example here. Now, we would always say that mouth breathing is the one which is the whole primary causative factor. But I would say that it's just a merely related symbiotic factor for malocclusion. Now, Dr. Weston Price, back in 1939, was the first one who found that there's strong correlation between diet, mouth breathing, cavities, and malocclusion. Now, when we look at this picture, look at this tradition in the current generation diet. These faces were so nice and wide. They had no crooked teeth, well-lined teeth. As the diet started changing, the facies started becoming longer. The nostrils started becoming narrow. The growth pattern became downward and backward, and that caused crooked teeth. So I would say that was actually the primary causative factor, and malocclusion. But mouth breathing was simply a merely symbiotic related factor. Can we have the first video playing here?
Yes, here it is.
What am I doing? Which way should I go?
That depends on what you see.
How convenient. Enter omniscient monkey right on cue.
Well, you know what they say. When the student is ready, the teacher appears.
That's it. No more fortune cookies for you. Hey, where'd you come from?
Oh, the better question is, where are you going?
Oh, someplace wonderful.
You didn't happen to catch the song I
You didn't
sang
happen
a
to
few
catch the
minutes ago,
song I
did you?
sang a few minutes ago, did you?
Why didn't everybody?
To recap, I want to live in some beautiful place outside. A carefree place where I don't have to hide or worry.
Life without worry. Music Hakuna Matata.
Hakuna Tomata?
Hakuna Matata. It means no worries.
Perfect. Mind taking that stick of yours and drawing me a map up? Oh, hey!
To find it, you must look beyond.
What the heck is that supposed to mean?
It means look beyond what you see. Beyond what I see.
Get a load of the monkey getting all existential on me. Beyond what I...
So that was a little snippet from the cartoon Lion King. It's my all-time favorite, and it was a very simple and a small message that they give, that we really need to start looking beyond what we were actually seeing from now. We really need to start thinking in a different way, change our thought processes in a different way. And I'm going to go back to my screen share again. And here we are. So there was this another interesting study where they again had 35 children, and these had SDB. They treated with adenotonsillectomy, of which only 18 of them performed the oral myofunctional therapy, while the remaining did not perform. Now, what was the interesting finding here was that definitely the ones who didn't perform had a relapse. But what they found here was that it is very important to assess mouth breathing not only during the day, but also during the sleep time. There was this another important research, which says that mouth breathing and low tongue muscle tone were highly associated with the high respiratory event index. And what they also found that craniofacial risk factors were having more pronounced effect at a younger age. If craniofacial risk factors are playing an important role at a younger age, here we are. That's our role as a pediatric dentist, airway or myofunctional orthodontics should be the new normal. So what is this airway orthodontics? Airway orthodontics is, first let me tell you what is orthodontics. Okay. It has more of an aesthetic focus where they are only looking at straight teeth. Whereas airway orthodontics, we are looking at function. So we're going to look at treating causes. We are looking at better airways. We're looking at more stability. We're changing growth patterns here. And we're also looking at straight teeth as a byproduct. So can we also play the second video?
Here it is.
Yeah. I think I'm going to...
Problems. I had no functional issues previous to orthodontics. Okay. So maybe there were some breathing issues or problems. I had no functional issues previous to orthodontics. Okay. So maybe there were some breathing issues or maybe I never used to snore. That was another thing. I don't snore still till date, right? But there was no functional issues as such. Now I feel with my joints clicking and popping sometimes, right? So post orthodontics, my teeth came into position, right? You can see my bite is compensated for, right? But what happened in bargain was my chin was pushed back and down, right? So if I leave my lips at rest, it shows a lot of my lower incisors, right? And that has increased my interlabial gap significantly. I've never had any issue with closing my lips pre-orthodontics. Even with my teeth protrusion, I used to do fine because there wasn't this, my lower lip didn't used to hang pre-orthodontics. Post-orthodontics, this has been an issue. So I've been struggling. That's why my lower lip has become a lot thicker, right? because I continuously try to purse my lips close. So in that scenario where I try to close my lips forcefully, because orthodontics has pushed my face down and back a bit, right? I'm not saying it was perfect before this, but it has done that to some extent, and I can notice that. So what I try to do is I try to close using my lips, and I recruit a lot of other facial muscles. And previous to this, I had no such asymmetry in my face, which is now which I can now notice. It's quite minor, but I can notice it in the photos. Like, you have to be looking for it, and even then I can see like my jaw is getting canted a bit on this right side, where I'm putting much more pressure to close my lips and obtain a natural lip seal, right? So I can feel like the right joint is suffering a bit. So this has been caused because maybe like the interlabial gap has been increased a lot. So that's an issue I feel that orthodontics doesn't address, right?
Could you even tell me about what you felt as a child, like about the habits, and what you said that you could relate to some signs like moodiness and all of those things as well?
Yeah, like basically for all my school life, like even if when I came to learn about orthotropics, myofunctional therapy, and all these things, like I started noticing my childhood pictures, right? Even from the start, when I was born, from the get-go, I had like always an open mouth posture. Like, you couldn't be right saying like I was mouth breathing, but I never felt like I had like we take these things for granted, because bedwetting as a child is taken for granted. Like, that's what children do, right? You just have to be trained. That's what people thought. But I could feel a lot of things, like academically. When I was in school, I used to feel completely lost. Like, I wasn't there. When I was there, I was mentally there, right? And back in my house, I was completely hyperactive. Like, I was a ruckus, right? Even so, like late into my teens, my mother had to get me some sort of medications that would slow down my metabolism, or like make me a little less active, right? So that was the thing. Like, when I was, and even into my preteens, like that was the main part. Into my preteens, that was when I started noticing like I had trouble breathing. There were moments when I was sleeping alone, and I could feel like I can't breathe, I can't get a full breath in, right? So maybe down the line, I started compensating it by mouth breathing and leaving my mouth open. And I didn't know like that was. I thought that was a normal thing, right? Because you never notice these kind of things unless you are aware about the issues. Like, mouth breathing is wrong. We're not told about this when we are children, right? Nobody tells us about this. Not even your parents. Like, it's not like they don't care. They just don't know. Like, there are issues. So that's what I felt. And
so how long were you thumb sucking then?
Thumb sucking. I was pretty long, right? And like into a 9th or 10th standard, maybe 9th standard. Yeah, 9th, 7th, 8th, 9th standard. So pretty late into my teens. I used to have it.
Ankita, you have to switch on your microphone.
Yeah.
Yes.
So what this boy was saying here is that he is 23 years old, and look what has happened when we are not focusing on the causes. He's just corrected his teeth aesthetically, but what about the growth pattern over here? What about the SDB here? This child was thumb sucking till 14 years and 15 years of age. Do you think this happens because of psychological reasons? I don't believe that over here. Like, he's having trouble with his TMJ at 23 years of age. He is not being able to close his mouth. after an orthodontics is performed. As a child, he was facing bedwetting. As a child, he was also facing hyperactivity issues, and where his mother had to actually give him medication to reduce his activity. Like, this is exactly what I'm saying, that we need to start looking at the bigger picture. We need to evaluate everything rather than just aligning teeth over there. I'm going to be starting my screen share again. Yeah. So, what are the differences?
Yes, full screen. Yes.
Orthodontics and AV orthodontics. So, orthodontics is going to move your teeth, whereas AV orthodontics is going to look at your growth pattern. Orthodontics, the active treatment starts at 10 and 11 years of age when all the growth is over. Whereas in AV orthodontics, we're going to guide the growth right from 3 and 4 years of age. In orthodontics, we are only looking at pushing the teeth back. But what about the arch length? What about the width of the arch? So in AV orthodontics, we are going to look at a forward growth as well as nice wide jaws. Orthodontics requires extraction sometimes. AV orthodontics completely avoids extractions. There's a high tendency for relapse in orthodontics and use of retainers because we are not correcting the cause. Whereas when in AV orthodontics, when we are looking at the complete cause correction, we are preventing relapse and there is going to be no retainers. As we already mentioned, the airway space is more important in AV orthodontics. Orthodontics is more mechanical, whereas AV orthodontics is more postural. We are also going to look at training the muscle tone and function. So as we observed in this child, orthodontics, without looking at the growth, actually caused the damage to the TMJ. Whereas AV orthodontics would have nicely widened the arches, pushed the teeth behind, and we would have improved the TMJ stability and function here. So I think there's some problem with the screen sharing happening now. Yeah.
Okay. Maybe.
Should I leave and rejoin, or what should I?
Yeah. You can click the link in your email, and you will be able to rejoin me. I will remain the live into the live, but you can do that.
Okay, I'm good.
Yeah. Let's try. I have done something. Let's see how many can join. Hi friends, are you able to see us? Are we visible or audible to you?
I think so, sir.
And oh yes,
Yeah.
yes.
Yeah.
Maybe I could do something. Let's see. Say how many people will join back. You can also, maybe in a group, you can say to re-log in. Dr. Marisha's slides will be there soon because somehow we
Not yet started the screen share. We'll share it.
Yeah. So actually we went offline. So Preeti's slides will be there. You can start your slide screen. Yes. I have already mentioned to many. Please re-log in. Oh yes, now they can join. Yes.
Okay.
Now I'm getting so many messages. Yes. Good. Yes. And oh yes, now the number is getting increased now. Previously
Okay,
it was
sir.
95, now roughly 134,
Okay, sir.
and but total we have 499.
Sure, sir. So no problem. We'll wait for like 5 minutes.
1 minute maybe, because most of are able to join. Please fine, continue. And by phone. Okay, so 1441 out of 499. It's working. Yeah, Garima is already in. Tanya is already in. Dr. Parimala, Rashmi, Swati. Please join again now. But Shobha ma'am had the problem like ma'am says it's over.
Yeah,
Over
yeah.
from that. Okay. Thank you, Mesa, for the feedback that you're again back to the platform. Okay. I think most of are there.
Okay, sir.
Yeah.
Do you want me to start?
Yeah, I think we can start.
Okay. So I'll just go over the slide again. Now, this was like a clinical case study of 2 case reports. Now, they came across 2 kids with class 2 malocclusions. They also had some signs of SDB like clenching, mouth breathing, poor growth, and they got treated with some myofunctional appliances and oral myofunctional therapy. And they realized that in 6 months, the AHI scores completely dropped. So myofunctional therapy and myofunctional appliances definitely work. But I also want you to understand that there are certain limitations for these prefabricated appliances. So you should select your cases accordingly. When I'm telling you that I want you to look at the complete picture of airway orthodontics. I'm not saying that only a removable myofunctional appliance can resolve every issue out here. Now, what this research is telling us that orthodontia has always asked us to just wait and wait till all the teeth have erupted. But what do we do about the brain development being completed? What do we do about the facial growth being completed? And Dr. Bowman says that it's a very ignorant man who is taking this responsibility for advising a delay in malocclusion treatment, which has been already seen by us. That's when I reckon we need to start early. The current standard of care is always when the patient is on fire, okay, now let's intervene. But why can't we start when there is just smoke? Why can't we intervene when the tonsils are not so big? Why can't we just intervene when there is mouth breathing? Why can't we intervene and prevent them from going through the multiple consequences that they will have to go through while facing OSA? The more we delay it, the more difficult to change the facial growth pattern. we can only work on masking, and how many disadvantages of masking are there. Definitely, there are a lot of surgical options available at a later age, but who really wants to undergo a maxillomandibular surgery? No one wants an MMA surgery happening, right? So what I'm trying to say over here is it also takes a village to cure problems related to SDB, but we all should know our role in SDB, and we should be able to refer and send the patient along the right path for correction of these problems. And Dr. Gimeno, he's the father of sleep medicine, actually, and he's the one who has coined the terms OSA and UARS. And he's also the founder of this journal, Sleep. So what he said is that it really takes a multidisciplinary approach involving pediatric orthodontists, involving oral myofunctional therapists, ENTs, and a lot of other mainstream medical professionals to correct problems related to SDB. So my team takes a very great approach where we look at structural issues, that's your jaw, growth issues. We also look at tongue ties, tonsils, nasal obstructions in conjunction with ENTs. We also provide myofunctional therapies, and we also look at behavioral problems, which is your sleep hygiene problems. Sometimes it is just your normal sleep hygiene issues which are showing you problems like SDB, but you don't really need any other treatments other than just a simple sleep training. We also can consider nutritional considerations and also some physical therapy options. So this was this one child who came to us with mouth breathing, and on further history taking, we realized that she had a lot of symptoms of SDB. And when we corrected her with myofunctional therapy, this parent saw a complete change in the lip closing during the daytime as well as during night. There was no bad breath. She had a very good oral hygiene later. She had frequent colds and cold cough allergies before, which completely decreased later. She had difficulty in organizing tasks. She used to get irritated quite often, which was completely resolved. So this is what myofunctional therapy can do, or myofunctional orthodontics can do, when we really relate all problems together. This was another child where this child was aged 6 years, and actually he was almost 5 when we started him. He was a class 3 malocclusion who was asked to wait before starting orthodontics and was asked to wear a headgear. But with the help of a combination of airway orthodontics, we could correct this child completely. This was another kid. I'm extremely sorry for the quality of the pictures because these are taken virtually. With the pandemic on, the patients have clicked pictures and sent it to me. We've been consulting them only virtually right now. And this was another kid who also represented with a deviated nasal septum. And she also had signs of SDB, a class 3 malocclusion. And she was asked to undergo a headgear treatment. She's 9 years old. But we said that why not, let's try it with airway orthodontics. And I feel I can avoid the whole headgear. And when I started working on the actual cause, which was the breathing, the maxilla just grew forward. I haven't done anything except looking at expansion here and correction of exercises, that is oral myofunctional therapy, and we could get the child over here in around 8 months' time. So I always say that our mouth is the entry to the health status of the person. And where are we? Like, just do nothing, it is all impossible, or just do it, nothing is impossible. And it's real, the time has come for pediatric dentistry to develop a new thought process. We can think out of the box and resolve this epidemic of sleep disordered breathing. And believe me, there are more cases of sleep disordered breathing than coronavirus right now. I really thank you all for listening to me. And we're also coming up with some exciting learning opportunities. You all can get in touch with us also. And I'm very happy to answer whatever questions you all have right now. So I'm going to stop the screen sharing and get back to your questions now. Yeah. So can we have the questions going in?
Ankita, I will put all the questions. Actually, what happened when we switched off the platform, all the questions were lost.
Oh.
I could not get back to all the questions, but I requested all the attendees to post their questions again so that they can go through. So we have a question from our friend Dr. Amrita Gogia. She is practicing in New Delhi.
Right.
How often you would need to do sleep study to make a diagnosis of SDB?
Okay. So let me explain you PSG. Okay, sleep study is polysomnography. You're actually going to put in a lot of wires. There are home sleep studies as well as in-lab sleep studies. So this whole wire thing with so many meters is also going to cause disturbed sleep for the child already. And a PSG cannot recognize whether the child is an apneic mouth breather, a UARS, a noisy breathing. It can only recognize moderate and severe forms of sleep apnea. So when you are reaching sleep apnea, we already know that it's hardly 1 to 2% in children. But what about these other children? Are we really going to ignore that? So the most sensitive and sensible method right now, which is used in globally, is to use a video camera screening. So I always advise my patients to shoot a 2-minute video of your child sleeping, but I advise them to take it around 4 to 5 hours after they go to bed. So that's the picture which I will get of what the child is doing in deep sleep. So they also recommend that you can install a little video camera in the room and you can actually observe every hour of sleep. I hope that will answer that question.
Okay. Ankita, there is a question from our teacher, especially your guide, Dr. Shobha Deshpande. Do we have to assess pharyngeal muscle tone to understand the issue?
So we obviously assess all the orofacial muscle tones. So when we actually get into details of oral myofunctional therapy, that's another big session where we need to assess facial muscles, also the intraoral muscles near the soft palate. If that is causing any obstruction, then we work on soft tissue muscles. So the main key here is get the whole picture, understand what is causing the obstruction, and that's how we plan the whole treatment behind it.
Okay. So then there is a question by Dr. Karuna Sharma. Does that mean that all mouth breathers will have SDB?
Okay, so mouth breathing itself, Karuna, is a part of SDB. SDB, as I said, it's a spectrum. So it has mouth breathing, it has noisy breathing, it has UARS, and it has OSA. Not all mouth breathing progresses to sleep disorder, OSA, but OSA always starts with mouth breathing. And there have been n number of researchers showing that mouth breathing, noisy breathing, and UARS itself are also affecting the growth hormone. That is also affecting the brain development. So we did not wait till OSA starts and we let these things get affected. So we rather jump in early and correct mouth breathing.
Okay. Then there is a question from Dr. Vishesh Singh. She is a postgraduate in KGMC Lucknow. Why even after surgical intervention, the airway ceases to become normal in growing children?
I didn't really get your point, Doctor. Would you be able to get me the question in a little more structured form? Whoever asked the question, if you can make me answer.
So Vishesh, if you are listening to me, please elaborate your questions. I will definitely get back to your question again. Now we have a question from Andrila Ghosh. She is a postgraduate in Guru Nanak Dental College, Kolkata.
Okay.
What is the relationship between asthma allergic causes in children with the airway dimensions and mandibular position?
Okay.
And also, lateral ceph as a screening tool is reliable initially.
Yes. So, hi, thanks for this question. There are a lot of questions into one. I'm going to go part by part over here. And let me make you understand that when mouth breathing or asthma or allergies start, there is a lot of role of even systemic inflammation here. Okay. So also an environment also plays a very important role of what is starting it. But mouth breathing or any form of sleep disordered breathing can worsen also these symptoms because you're exhaling out a lot of carbon dioxide and you're not making enough nitric oxide. So this is going to increase your tendency towards allergies, cold, cough, tonsils, adenoids. So when it comes to tonsils and adenoids, it's like chicken first or egg first. A lot of them say that because there is tonsils and adenoids, you start mouth breathing. But there is another school of thought also where they say that it's your body's response, because when you're mouth breathing, you end up breathing out a lot of carbon dioxide. When you breathe a lot of carbon dioxide, a signal is sent to your brain that you're breathing too much and you need to slow down your breathing. So when you tend to slow down your breathing, what are you going to do is you're either going to have a little decrease or a complete stoppage of breath. Okay, now when that is happening, it's your body's response to develop those lymphoid tissues. So it blocks your airway to decrease that breathing. So this is another school of thought where mouth breathing can also increase tonsils and adenoids, and tonsils and adenoids can also increase mouth breathing. But n number of researchers have always shown that even if you caught tonsils and adenoids, mouth breathing still persists. And it, in fact, relapses the tonsils and adenoids. So this second school of thought is really related over here. And we should be, again, looking forward to correcting the breathing there. And the last question they put up was regarding the lateral ceph. Yes, lateral ceph is a very reliable tool. Now, globally, most often they take CT scans. But with children, even they prevent CT scans to avoid that level of radiation. So everyone assesses from the lateral cephs, and we can identify the adenoids there. We can look at the anterior and the posterior nasal space over there.
Okay. Thank you, Ankita. There is one more question by Dr. Anirban Chatterjee. He is the practicing pediatric dentist in Pune.
Right, sir.
What would be the standard investigation procedure or protocol for airway measurements in pediatric SDB cases?
Okay. So, sir, I generally go through a lot of questionnaires. Now, there is this PSQ scale, Pediatric Sleep Disordered Questionnaire, easily available online. And you can Google it up also. It's easily available on Google. I take down that questionnaire. I also look at the video of the child sleeping. I look at the facial structure. I observe the child when the child walks in front of me. And I make my diagnosis from there. That is the child a suspected SDB or no? Then I send the child for, if I feel that there has to be something related to the airway space, I need to keep a watch into it. I advise a lateral ceph. I go look at the adenoids. I look at the anterior airway space and the posterior airway space. And it also gives me an idea of the growth pattern. So if I feel the jaws are retruded, I want to work on those jaws and get them forward. And if that is really causing the problem. So I hope that would answer that question.
Yes. Then we have a question from Anhita Gupta. She is a postgraduate in BBD Dental College, Lucknow. I think so, if I'm not wrong. What is the clinical difference between habitual and obstructive mouth breather?
Okay. So, Anita, thank you for this question. As I mentioned, there were some tests where you are going to grade through the mirror fogging. You're going to see the fogging. You can have a water retention test. Ask the child to hold the water in the mouth for 3 minutes. You can also ask or put a little tape. You can use a micropore tape also, just to cut down the cost. You can just use a micropore tape. Ask the child to hold in for 3 minutes. If the child is not being able to hold over there, that means there has to be some form of obstruction. But if the child is comfortably holding, that means the child is habitually mouth breathing. It's not some obstruction that is making him mouth breathe.
Okay. Then there is a question, Ankita, from Dr. Sarvana Kumar.
Yes,
who
sir.
himself is a lot into these kind of therapies along with the laser.
Right.
What tool you prefer for tongue tie release, laser or Caesar, and why with evidence?
So for infants, I prefer lasers. When it comes to cooperative children and a little adult children, I love scissors because there is a different technique behind it, where I got a great mentorship from Dr. Surush Zagi, where I was actually proctoring under him, and I learned the whole how he does the procedure. So I was really amazed to learn the whole procedure of frenectomy with scissors, where you can really dissect everything out. So it's a very different approach. It requires a lot of detailed anatomy and training into it.
Okay, because this question actually has comes from the master. Because
Yes.
I know Sarvana, he's doing a lot of things and work in this field.
So I didn't speak too much about tongue ties because I don't want people to go back and understand that everything is a tongue tie. Everything is not a tongue tie here. You really need to look at a lot of other things also.
Yes. And then we have a question from Vishesh again. How
Yes.
do we need to do muscle examination also in case of mouth breathers? And if yes, how?
Yes, you need to examine muscles in every case. And so that's a whole part of oral myofunctional therapy. Again, that's a very long session where we look at buccinators, we look at the orbicularis oris, we look at the hyperactive mentalis, we look at soft palate muscles. So there is much more detail towards it, which I will not be able to answer in like 1 or 2 minutes, but I can give you like a little highlight. When we look at the cheek muscles, your lower border of your mandible will not be visible. It will be covering it. It's not going to be very well defined. So that's a hyperactive muscle. When we look at the mentalis, we're going to get this puckering over here. So that's again a hyperactive muscle.
Okay. So, because I have to look at the WhatsApp chat also and this chat also, because few questions come there, a few questions come there. So we have a question from Cosma S.
Yes, Cosma.
This name is not there into my contact list, I think.
Okay.
What is the key finding which gives a clue that the child has SDB, which can be analyzed on a day-to-day practice and confirmatory test for the same?
So, Cosma, there is no one thing that can cause SDB. There are multiple causes, as I mentioned. So you have to take the questionnaire. You will have to see the video, how your body is also compensating for it. Is the child sleeping with an extended neck? That's also one of the signs, because the parent is not going to realize that an extended neck means the child is trying to open up the airway. So there are multiple things to it. And as I mentioned, the risk factors and the causes before, questionnaire and your sleep imaging, like if you take a video, these all things together will let you come to a diagnosis of whether the child is an SDB or no.
Okay. Mm-hmm. And we have lots of wishes and praises, like from Dr. Shobha Tandon Madam. She has greetings and wishes and blessings, I'll say, rather blessings.
Thank you, ma'am.
And then we have Dr. Avula Sankar sir has given Prerna, Rakesh, Maisa. Then Dr. Harpreet, she's from Punjab, Jalandhar. Then my previous speaker of the webinar, Dr. Kumar Gadam. How did you correct crossbite with a functional exercise? Let me tell you, Ankita, this is a question from the master itself.
So this was like a challenge for me, where everyone had told me that you're crazy, you're not going to be able to correct this without a headgear. What are you thinking? And I was like, there is no harm in trying. Anyways, you are going to put your head here, right? I'm going to do what I want to do and what I know I think I can work around that. So I evaluated the whole questionnaire. I saw the videos. I saw the child having early signs of SDB. There was no one who actually told her that there was a deviated septum. I saw her facial profile. I understood that there is a deviated septum, which gave me a highlight that there is definitely a restriction with nasal breathing. I saw a lot of flatness with the maxilla as well. Her maxilla was not growing forward. So I unlocked the jaw. I worked on, I used MyoBrace because that was the most easily available for me. And I worked on myofunctional exercises. I strongly worked on a lot of breathing. This breathing helped me grow the maxilla forward. And it was very surprising to know that the breathing could bring the maxilla that forward. And for the posterior crossbite and the narrowness of the arch, I used expansion plate and I corrected it with that.
Okay. There is a question from Sanjana Bhargav. She is a postgraduate in Bhopal People College or People Academy, one of the college.
Right.
She has two questions for you. Two questions. Her first question is, how the soft diet causes SDB? The second question is, at what age the sleep disordered breathing starts?
Okay. So, Sanjana, as we know that soft diet is something what you and me are also having. We are having roti, chapati, sabji, everything is refined. We are not actually having anything crunchy. Do you last remember when did you have a salad? Did you really use your muscles of mastication? It's our modern generation where everything is refined from flour to everything. And we are all having narrow jaws. Even I had an impacted third molar. Why did I extract? Why did God give us a molar when it was not required to be in our mouth, right? If it had to be extracted, that was not the case. So our jaws started becoming narrower because of it. And that narrow jaws actually caused the airways to become narrow. And there was a second thought, not to soft diet, but processed food, that is packaged food, has a lot of carbon dioxide. So when you're generating a lot of carbon dioxide in your body, you have to exhale that out also. So the way to exhale it out is mouth breathing. And that is how a small science. So this is more through the Western world where a lot of packaged food is used. In India, still packaged food is used to a lesser extent, but still more than the previous generations, I would say. And so what was the second question? I just...
What age? At what age this SDB starts?
Sanjana, and SDB can be seen even at infancy. Like I've had infants who come in who say that they were kept in incubators, they had difficulty in breathing at 10 days of age and 5 days of age. But there was a different issue there. It was actually the problem with the tongue positioning. And that caused the SDB over there.
Yeah. So Ankita, when we had our last lecture, which I told you that the question comes from the master, he is Kumar Gadam. So he insisted for the diet, the hard diet, not the soft diet for the young kids.
Yes.
Like, for his son, he told like what procedure he followed, because he gave us example of a guava that he used to choose the best guava, but he never offered that guava to the child. And then he himself used to ask, like, you give me the guava. Like that, they made a habit of giving him a hard food, not the soft, right?
I totally agree to that, because what I've seen mothers nowadays, they're only puring the food like till 1.5, 2 years of age. I was like, they can eat normal food. Why can't you give them normal food?
Yeah. So he insisted for that.
Yeah.
So now Dr. Abhishek wants to know, Ankita, what is your treatment plan for the last picture of class 3 profile patient?
That's something which I told you before, Abhishek. So basically, I corrected with myofunctional exercises and breathing. And I use an expansion plate, a fixed expander actually, not a plate, to correct the crossbite posteriorly. The jaw was also narrow. And most of my problem was solved with breathing. The minute my breathing restored, the maxilla just grew forward. This is the growth potential of our jaws. As I said, the functional matrix hypothesis. Function and the tissues around it is restricting or influencing the growth of the jaws.
Okay. Then we have a message from Deviti Amrita Manal. Manal is saying thank you for your excellent presentation.
Thank you so much.
Then we have a question from Dr. Ilham Abbas. She is from Dubai.
Okay.
From what age do we have to start noticing the breathing problems in children? I think you have answered. Maybe
I already answered that. Yeah, right from infancy.
right from infancy. So I have a question from Dr. Jena from Bangalore. Respected madam, can you please explain the correlation of childhood obesity, mouth breathing, and OSA with its consequence on oral facial development?
Okay. So, see, obesity has always been related to OSA. The minute you have obesity, your diameter, neck circumference is going to be more. So it's going to cause a little strain on your airway. Okay, that's the reason why obesity and airway were linked. But how children with SDB can become obese is because you're having a disrupted sleep. You're not going from your light, deep sleep to your light sleep. So the hormones which are going to control your satiety are not being released. And that is when you're going to tend to have more food. You're going to feel more hungry because you're going to be drained out. And that's how you start becoming more obese, because you're not releasing the right hormones for satiety control.
Okay. And we have greetings from Monica. Monica is from Abu Dhabi.
Hi, Monica.
She is from Mexico. Vishwendra, Mahima, they're all from India. Shreas.
Hi.
Rashi. Then there is a question from Dr. Marisha.
Right.
If a child of 4 years having a tongue tie, retuded mandible, mouth breathing at night, bedwetting, occasional snoring, but no speech issues and excellent in academics, is the tongue tie to be relieved first?
As I said, I didn't really talk too much about tongue ties because what I've realized is that when people start recognizing a tongue tie, you want to relate everything to the tongue tie, but it's not that. Remember, I said muscle tone. If your tongue is not resting at the right posture and if the tone of the muscle is not correct, I will not move on to release any tongue ties. I will first work on my muscle tone. If my muscle tone is okay, if my resting posture of the tongue is coming okay with my myofunctional therapy, then that's it. I've solved the problem over there. You will come, correction of SDB will happen. And of course, I will obviously correct the retruded jaws also. But if I see, even after my therapy, that my tongue is not coming at the right posture, or if there is a severe tie, severe ties have no question over there of releasing, because they are not going to be able to reach the palate at all. But the question comes when it is that mid-range tie where everyone is like whether to release or not to release. That's when myofunctional therapy will play a very important role. Till you don't do therapy, don't release the tongue tie. Once therapy is done, muscles are okay, then think of the problem solving from there.
Okay. Thank you, Ankita. Thank you, Rashmi, for your wishes. Neha, thank you. Dr. Soti from Greece, thank you, Dr. Soti. And now we have a question from Rakesh Paila.
Yeah.
What is the success of analyzing deep disordered breathing and obstructive sleep apnea through child sleep habit questionnaire, a preliminary examination, chairside to analyze deep sleep disorder and in turn behavior changes in children?
So I'll tell you from my experience that it's nearly perfect. Like whenever I have like good 7-8 questions ticked at yes, I have an idea that the child will be a suspected SDB. A lot of times, even if I look at the facial features, I look at the muscle tone and I see the child with a little lip parted, I start my questions. No mom is going to come and tell you that, no, they'll always say that the child is not mouth breathing. But you don't have to rely on that. You have to look at your observations, look at the video. The sleep video really gives you all your answers. So that's when the parents will also start listening to what you want to say. So as I said, I create a whole signs and symptoms in front of me, and then I go and suggest that, yes, this child is an SDB and this is what it is causing. So as I said, you have to go or hunt what is that primary etiologic factor for that particular child, because every child is going to have a different etiologic factor. Find out what is the primary cause and treat that, and that's going to give you success over there.
Ankita, sometimes what happens, there is airway constriction because of tonsils and antibiotics, right?
Right.
And the ENT surgeon will advise tonsillectomy. But even after that surgery, the airway space is not available. It's not normal. So what could be the possible cause for that?
So retruded growth of jaws, if the jaws are behind and they've not grown ahead, then obviously the airway is not going to become wider. And tonsils and adenoid surgery, I would advise only when it's like a grade 3 and grade 4. And that would also not be my first line of treatment. I would start with breathing exercises for and correction of the oral musculature. The minute I start correcting that, a lot of times the tonsils and adenoids start shrinking. The minute mouth breathing is corrected, they start shrinking. You no longer need surgery. So I probably start with some nasal drops and put them on correction of the craniofacial growth simultaneously. But obviously I inform the parent that there is this, and we may look at it at a later stage if necessary. We will try to avoid the whole process, but we may look at it at the later stage.
Okay. Ankita, there is a question from Nirmal. What are the preventive measures for pediatric sleep disorder bleeding, and when should we start myofunctional therapy?
So preventive measures, I would say the earliest measure is breastfeeding. Breastfeeding can influence the jaw growth, and moms today have started using a lot of pacifiers and bottle feeds. So our key has to be to educate them to breastfeed. So when we look at breastfeeding, that's when we will come across a lot of issues with the tongue and the lips and everything. So that's your first stage of prevention over there. Another stage, diet. Change your diet. These are the things where you're going to avoid too much screen time. So whatever the causes I mentioned, if we can work on it, we are preventing it over there. And so what was the second part of the question? I just...
Second, when we should start myofunctional therapy?
So you can start as early as 3, but I would say not all children are very cooperative at 3 years of age. So you need to weigh your options, which child is going to cooperate with you, and start at that time. Nowadays, there are a lot of appliances available where they are okay to just chew on it also, myofunctional. So which is okay, like a 2 or 3 year old, if they can chew on that appliance, they're going to get the jaw ahead constantly. So you don't expect them to do the exercises, but even if we can influence the growth of the jaw forward, that works for them that stage. It will be phasic for them for sure.
Ankita, do we have some videos particularly which can help our attendees learn more about these exercises and all that? Do you have some videos like or link for the videos if you have?
So if you put it up on YouTube, I think you will get a lot of exercises on YouTube.
I would like to give you a homework before I give the homework to my attendees. So because you already know what the subject is, right? So if you can really help me in sending few links which are important and which will be useful for learning about exercises especially.
So they can go to my YouTube page also called Dentition. There are a lot of breathing exercises already put up there.
Just share a few links.
I'll share the link.
I will forward those links to all of them. Yeah. And whatever WhatsApp contacts I have, I will share all the links with them. And I think that will be really helpful for them.
Sure.
And then we have a question from Dr. Pushkar. Which exercise do you recommend? This was actually my question for you about the video.
Dr. Pushkar, there are n number of exercises, you know. You have to create your own, what works for you after understanding the science behind myofunctional therapy. So I would not, so if you are going to give you exercises just like that, okay, just do breathing, just do lip popping, just do cheek puffing, it's not going to work that way. So if you don't know what is dysfunctional, your exercise and what is that exercise going to do, you're not going to be able to correct it. So exercises are available online. The minute you type it, you'll get 20,000 exercises over there. But the philosophy behind it is different. You will have to learn that in detail.
Ankita, do we have some reading material, like any particular PDFs or any reading material which can be helpful?
So the articles don't give you so many exercises. You will have to do a educational program behind it. And we are looking forward to getting some educational resources here soon. And I will keep you posted the minute we have those resources.
Okay, so that will be really helpful because they will learn more about it.
Because it's a very detailed one. So it's not going to be something,
Okay, there is a question from Dr. Jaina again. A 7-year-old girl with all forms of developmental delay, having all the classical features of mouth breathing, what would be your choice of treatment, and can we start MyoBrace K0 appliance?
I don't know what is the facial profile. I don't know what's the airway looking like. What is causing it? So I'm going to first hunt behind my cause, and that will be my treatment plan. No MyoBrace is going to solve your game. So I don't want you to go back understanding that MyoBrace is your problem solving game. Not really. MyoBrace won't do anything. If you don't know what you want to target, it's not really going to do anything. So you need to understand your cause, and MyoBrace is going to give you all kinds of K0, K1, K2, K3. But when to use what? Are you going to use 10 appliances from MyoBrace? It doesn't work that way. You need to know your cause, need to know what you want to correct, and that's how you use the appliance.
Okay, Ankita, there is a question from Dr. Arpita Datta. She is a postgraduate student in IDS Bhubaneswar, if I'm not wrong. If a child of age 8 years who has the main complaint of protruded maxillary anterior, but on investigation, we found increased adenoids.
So I'll have to pause you. My battery is low. I just need to connect the charger.
Okay.
Give me a minute. Yes, sir.
Okay, so I'll continue with Arpita's question. That 8-year-old child is with complaint of maxillary protrusion, then increased adenoid cough, cold, and should we address this problem first, or should we start with the treatment of teeth?
Both will go simultaneously. So why is it happening? Did you have a look at the adenoids? How big are they? Correct the soft tissue dysfunction. And you will have to correct the jaw growth simultaneously. So both are going to go together. Okay,
that's wonderful. And then we have a question from Dr. Meenu Mumtaz.
Yeah.
Ma'am, what's your take on the use of steroids, right, on a treatment option for SDB?
Meenu, a lot of pediatricians will first recommend steroids, and I'm not too much in favor of steroids. I understand one-off instance where they give, but if you have to repeatedly give steroids, we are not at the right cause. You know what I said, that you need to identify the cause. So why is that happening? Is there mouth breathing, because of which? Is there some dietary constraint? Sometimes even a high milk content. Sometimes milk doesn't suit a lot of kids, and milk is tend to producing more mucus also. So is that also a problem? So you need to look at multiple questions before coming to this answer.
Okay. Ankita, there is a question from Sanu. She is a postgraduate in AJ Dental College, Mangalore. I think you have already talked about this particular topic, that is dietary changes, what you recommend for children. Maybe in few lines you can suggest.
Dietary foods are going to be raw, rough foods. I would always ask them to incorporate a lot of salads and nuts in their diet. So they're going to use their muscles of mastication. That would be my biggest key take on dietary changes.
Okay.
Less packaged food.
Okay. Then again, we have greetings from Dr. Rajkumar Amrita. Then again, a question from a master himself, that is a Jobby Peter.
Yeah.
How do you know the maxilla is hypoplastic?
How do I know? Facial profile will tell me a little bit, but lateral ceph will give me the answer if the maxilla is hypoplastic. We can look at the cephalometric findings and know from there.
Okay. Then we have a question from Dr. Vishal.
Yeah.
I think Dr. Vishal is working in Gurgaon. If I'm talking about the same Vishal, I could recognize the same.
Okay.
The time duration for the use of twin block once we start the treatment, and how long should we go for the retention phase?
I don't use a twin block. I generally work with a lot of expansion appliances, my removable myofunctional appliances. These generally have helped me. I have not encountered the need to use a twin block. I look at the muscle. If the muscle is pulling the jaw behind, the minute I correct that, the jaw starts moving ahead. If my tongue positioning is right, the jaw will start coming ahead.
Okay. Then Dr. Isra Ibrahim, thank you so much for your greetings. A question from Dr. Sankar. Role of pranayam in improving SDF.
Yeah, you can use it, like breathing. Like, see, what generally myofunctional therapy is going to use is a lot of forms of Buteyko breathing, and there are n number of breathing techniques available all over the world. You know, they have Buteyko, there's someone else performing some other form of breathing exercises. But in the end, it's just the role of breathing which is going to play. How much can you, lung capacity, improving the nasal capacity, breath holds, this is going to improve your jaw growth. So pranayam can work. Like, we can try yoga. Like, no one in the world has tried it, but yoga will work. I'm telling you, it will work.
Yes, definitely.
It will work.
Because our traditional ancient science will definitely help in this.
Yeah.
Yes. Dr. Shweta, thank you. Dr. Dritanyan Das, that already has been answered about the dietary, because we need to include lots of fibers, lots of salads, nuts, means hard food. Lots of fruits, hard fruits you can add, like a guava, as Dr. Kumar Gadam has recommended in the last lectures. Then Ankita has asked the same questions. Ankita Chanda, she's a postgraduate.
Right.
And thank you, Dr. Jobby. He's very happy with the answer. Then Dr. Madiha Khan. Ma'am, if a child comes in winters and parents complained about mouth breathing, but the child has cold and cough, should we start with the treatment or wait for some time, as it may be due to seasonal change?
See, if there's one-off incident of cold and cough, that is not going to give you an answer to SDB. If you have repeated episodes, then definitely you have to look into it. One-off incidents is really not a signal to SDB.
Okay. Because Madiha is a postgraduate in Bhopal, People Dental College, Bhopal.
Right.
Okay, then this is not a question. This is only a greeting from Sarvana. Then Dr. Jivarathan has mentioned any specific reason for not using twin block?
Not really, sir, but I till now, I have not felt the need. The minute I'm correcting the muscles, if I'm looking, I think the key is the muscles. If you are looking at the functional matrix, why let a child go through that tedious appliance? It's so big. If someone makes me wear, I don't want to wear it. So I look at it that way. If something which I wouldn't like to give it to the patient. So just over there, nothing, no regards to not being a good appliance. It definitely works, but I find it too bulky, and I rather prefer it the other way.
Yeah. So even Dr. Kumar has shared 3 books with me on the early intervention, right? So I have those books. So I have already shared with many of the people, like whatever the contacts I had.
Right.
Maybe you are added after I shared it. So
Right.
you can just remind me. I will share those books with all of you. And with that, I think we have taken all the questions. Thank you, Dr. Shobha Deshpande, ma'am, for your blessings.
Thank you.
And I think we are done with all the questions. And
Thank you.
I'm really sorry if I missed any. I never mean to miss any, but maybe because of some network issue, your question was not here in the platform. So that may be one of the reasons. But otherwise, I did not miss any of the questions.
No problem. So they can connect with me even on Facebook or Instagram. So if there's anything that they crop up later with their questions, they can always text me. I will happy to answer them.
Sure. Thank you so much, Ankita. It was
Thank you so much, sir. And I hope everyone enjoyed the presentation.
Yes. Many of the new things they must have learned. And definitely life has to go, and we will learn over the
Yes.
So I really thank you for
Thank you so
wonderful presentation, for making the task easy,
Thank you.
and hope it went well, although there was some technical issue in between,
Thank you.
but somehow we could manage, I think. Right?
Yeah.
Thank you so much.
Thank
you
you.
so much.
Thank you, sir.
And I thank all my guests and attendees for a lovely support and for being there. And I can see Dr. Adriana here, and Nizar Muzalid has joined me here.
Yeah.
Because he was attending IIPD lecture. He messaged me. I'll join you after my IIPD lecture is over. Good to see you. And good to see you, Sajad. And Dr. Nizar, yes, I would like to mention here, we have finalized 2 lectures now more. One will be on Tuesday. That will be by Dr. Dina Rabia, and it will be on caries risk assessment. She has so many things to say about caries risk assessment, and that will be on Tuesday at 7 p.m. Indian time. And Dr. Dina is a pediatric dentist who is working in 4 dental clinics in Egypt. She is from Egypt. And then on Thursday, we are going to listen from Dr. Fazal. He is from Malaysia. He is an honorary general secretary of a Malaysian Association of Pediatric Dentistry. And he will be talking about oral impalement injuries. And he will be talking about the review of the treatment protocols which are there. So we have these 2 lectures. And Sajad, you don't worry. I'm going to share the links with you. I have already saved your number. Although I was not having your Dubai number before, but now I have, so don't worry, I'll share. Dr. Nizar, definitely I'm going to share all the links with you. Maybe today I will generate a link and I will share the link with all of you. So first of all, I'll share the link for Dr. Fazal, because, Dr. Dina, because that is scheduled for Tuesday. So, and after that, I'll share the link on for Dr. Fazal, because that is scheduled on Thursday. So if anything more is needed, you can anytime get in touch with me. My number is already there. That is +91. Let me write +91. I can +91 98 554 666 and 66. That's my number. So you can just be in touch with me. I will save your number and make sure that you don't miss any of the webinar which we organize, or you don't miss anything from us. Thank you so much once again. It was a lovely evening. I really enjoyed hosting your webinar, Ankita. Thank you so much.
Thank you so
much. And thank you all attendees. I'll see you on Tuesday. Tomorrow is our off day. We are not working as far as the webinar is concerned, but I'll see you on Tuesday. And till Tuesday, please take best care of you and stay safe. Thank you so much. Good night. Bye bye. Take care.
Thank you. Thank you.
Bye bye.
Bye.